mainly what we're going to talk about in this lecture is insulin. All right, get your blue boxes ready. A 66-year-old female patient has a 7-year history of type 2 diabetes that's been well controlled with glipizide, 10 milligrams a day, and rosiglitazone, 8 milligrams a day. Over the past year, her glycemic control has deteriorated, with her most recent laboratory test revealing a fasting glucose level of 185 and a glycosylated hemoglobin level of 8.9%. Her serum creatinine is 1.7. Which of the following would be the most appropriate intervention at this point? So, long-standing type 2 diabetes, she's on Avandia and glucotrol, really at pretty much max doses, not controlled, A1C of 8.9, creatinine's 1.7. All right. Everybody have a chance to answer there? All right. Oh. So the best answer is begin basal insulin. It's like 7% of our respondees mentioned adding metformin. Problem with that is her creatinine is 1.7, and so you don't want to start metformin on somebody that has a creatinine of 1.7. All right, this is just a reminder slide. Over time, glycemic control worsens, and this was just from the UKPDS, where they started out in both groups were about at 7%, but over time it just shows you that insulin production goes down by about 50% every 5 years. And so because of that, insulin becomes a therapy that's needed for most diabetics. This is another slide that shows a similar type effect, and it shows the declining beta cell function. Most people when they're diagnosed, their beta cell function and production of insulin is going down as they're diagnosed. And then every year, about 5 to 10% of your beta cell function goes down, and most patients eventually need to be on insulin. And that's why we have this lecture. This was just from the NHANES, or National Health and Nutrition Education Survey. This was in 2004. And this is just a slide that shows really most diabetics don't reach recommended glycemic targets. In fact, at that time, about 2/3 of the patients had A1Cs above 7%. Only 37% of type 2 diabetics at that time had A1Cs less than 7. So what I'm trying to do is make an argument that you need to learn how to use insulin and be comfortable with it. You all live in an era in which it's become a lot easier because of some of the newer insulins than some older physicians. But anyway, here's the thing that's why it's difficult. Number one, people are often diagnosed late. I mean, you don't have a lot of symptoms of diabetes until you are way down the road when it comes to polyuria and polydipsia, and you know those don't happen until your blood sugars are consistently above 170. That's when you start having more of those symptoms. And then the other thing is just inertia. I mean, the hardest thing to do is to change what you're doing. And so if that's a diabetic, trying to get them to do some type of wholesale life change, diet, exercise, start insulin, they're like, what? It's just such a massive thing, and that's why we have to think about using diabetes educators and be patient with these people, our patients, as we try to move them along. And then, of course, we talked about many of the adverse effects associated with some of the treatments. And then just the complexity of care. These people have high cholesterol, hypertension, and then lots of other things too. They come in with joint pain. They come in with mood disorders. They come in with allergies and COPD. And so it's not just one disease we're treating, but there's a whole host of things that make them complex. And so there's a lot of reasons why we don't transition to insulin as frequently as we really ought to. These are some of the concerns that patients have. Number one, people are scared of injections. They think injections hurt. And if you've taken an insulin injection, you know that, hey, this really doesn't hurt. 31 or 32 gauge needles that are 3/8 of an inch long, you don't even feel them. I mean, they literally, it's like, mosquito kind of bite kind of a deal. I mean, it's just insignificant amount of pain. So try to help. If you've never taken one, just if you have one of the pins from a drug rep, take the needle, don't give yourself insulin, but put it in your arm and just see what it feels like. But it doesn't hurt. And so let your patient know that. This really is not a painful thing. It's a 31 gauge needle. People fear low blood sugar. They've heard horror stories about how he had a diabetic attack or something like that. And then, of course, people don't like weight gain. There's other things, too. People, view it as, man, I must really stink as a patient. My sister, she could be on pills and I have to be on insulin. And they kind of view it as a personal failure. And I would teach you or hope you would kind of rephrase that and go, listen, you haven't failed those therapies. Those therapies have failed you, and we've got to use a therapy that's going to work for you. And so let them realize that it's a progressive disease and that people often need to be on insulin when they have type 2 diabetes. And so try to get them past that where they have this as just the way it is. And the other thing is say, you know what? You sometimes have to be a bit of a salesman and say, this hormone we're giving you, it's identical to the insulin that your own body makes. It's a natural thing, which is maybe a little bit of a sale, but in the era of we like to only get things that you can buy at the health food store and all that. You say, hey, this is a natural hormone, and I had one endocrinologist who liked to use that phrase. I just prescribe natural things. Then there's also a belief by some people, they're like, oh, their diabetes was really severe. They had to be on insulin. And so there's just some things that you have to get past that whenever that gets in the way of a patient accepting the fact that when you tell them that. But so often when people that need to be on insulin get put on insulin, for example, like the guy I was telling you about in my practice, it's a 32-year-old guy that had the horrible blood sugars. He's getting up at night 2 or 3 times a night. He feels poorly. He's lost weight. He's thirsty all the time, and you put him on insulin, you reverse all those things, and he's like, oh, wow, this is really nice. I feel so much better. And the harder person is when they're on 2 or 3 drugs with an A1C of 8 and not having horrendous symptoms, getting them to transition. The thing I mentioned that you live in an era when it's a lot easier, and that's really because of basal insulin therapy, but you also live in an era in which perhaps it's somewhat harder to because you have more options. And this lists the complexity or the different insulin options, and we go from simplest and maybe perhaps least physiologic to the most complex, the most flexible, and also the most physiologic. So I have an insulin pump, and at the top, that's up here, it's physiologic. You take insulin when you need it. You can turn basal rates down if you're like saying, well, you know what, I'm going to go for a 5-mile jog today, so I'm going to turn my basal rate down. And you can, but it's complex. I mean, you got to have a patient who's willing to check their blood sugar 4 times a day and willing to learn about carb counting and those kinds of things. But it does provide a lot of flexibility. Versus basal only, when you take a shot of Lantus, you've got to plan your whole day kind of around that dose of Lantus. So if you decide to go on a 5-mile hike, which perhaps a lot of type 2 diabetics don't, but you know what I mean. I mean, it doesn't allow for a lot of alteration within your day-to-day schedule. So, and in between, you've got other options, multiple daily injections. You've got your pre-mixed insulins, your Novolog 70/30 and those types of insulins, which are pre-mixed. And then you can also mix insulin with regular and NPH and as well. So there's lots of options. And what I want to try to do today is to make it simple for you. I think you need to have 1 or 2 ways that you do it, maybe 3 ways. But if you can come out of here and you feel comfortable with 1 or 2 ways today, then I think you've accomplished a lot.